Thank you. So I will try my very best, but a short statement. So I'm the only surgeon here, and I'm absolutely convinced that necrotizing pancreatitis is not a surgical domain anymore. So we do nearly zero cases of surgery with necrotizing pancreatitis. But now it's pancreatic cancer, and I start with a little provocation. This is maybe a lot of you know this statement: pancreatic resections have minimal impact on survival rates and are wasteful of resources. And you may say, okay, this is an old paper, but this is a more recent one. Peter Malverheimer. Malverheimer is the head of the gastroenterology department in the University of Magdeburg. And if you see, it is very similar. The stress of surgery is poorly tolerated by many patients who either die, develop complications, or are then unable to receive adjuvant chemotherapy. In the end, although many patients undergo resection of these tumors, only very few will benefit from a true surgical cure. So this is a statement that is hard to bear for a surgeon, and so I looked into the literature and I found this nice paper some 10 years ago, published 9,500 patients with early stage pancreatic cancer, so only T1 or T2N0 observed over a time period of 10 years in the United States. And the very interesting finding here is that only a certain part of the patients were operated. So if you look at this, these are the patients that refused surgery. These were too old or had contraindications. These were patients that were operated, nota bene, only stadium 1 pancreatic cancer, and around 40% of the patients were not offered surgery at all. And these are the survival rates. You see, if you don't undergo resection for early stage pancreatic cancer, your prognosis will be very poor, similar to stage 3 or 4, which do not undergo surgery, and you have a much better chance if you undergo resection. And this is about the relevance of lymph node metastasis. These are this is a 7th or 8th edition of the American Joint Committee of Cancer, and in the 7th edition they differentiate only between N0 and N1, and if you have no lymph node metastasis, your prognosis will be much better. And in the 8th edition they differentiate between N1 and N2, and you see you have a nice correlation between the involvement of lymph nodes. Here you can see it again. So the more lymph nodes that are infiltrated by the cancer, the worse is your prognosis. What can surgery offer? We can nowadays offer a very low mortality rate of realistically below 5%. We performed an own study in the clinic in the Klinikum Stuttgart, where we distinguished between old and not so old patients. The limit was 75 years, and we had a survival rate, so a mortality rate of the patients below 75 years of 0%, and these were 220 patients. So what you can expect from us is a relatively low mortality rate. The morbidity rate is relatively high. And one problem in pancreatic cancer surgery, and this means that you have to have good collaborators regarding gastroenterology and radiology, is the management of the complication of surgery. This is our data, and 3% mortality rate overall in the last 6 years. And what is, in my opinion, important, and I will address that afterwards, is the frequency of portal vein resection. So if your surgeon is not willing to do portal vein resection or cannot report the portal vein resection rate in his own institution, then maybe he's not really dedicated to pancreatic surgery, because this is important. You see, we do around 10%, and to my opinion, it's a surrogate marker for quality in pancreatic resection. So what I would like to discuss is the question of evaluation of tumor resectability, vascular and multi-visceral resections, resections in case of limited distant metastasis, neoadjuvant therapy, and recurrent disease. So how do we define resectability? This is from the MD Anderson Center, from their homepage. This is clear, these patients are resectable. More interesting are these patients, type A. This is our problem, and these patients we do discuss in our tumor conference together with our gastroenterologist, because these patients with tumor artery abutment, mesenteric, superior artery and celiac trunk, these patients are candidates for eventual neoadjuvant treatment. And this has to be discussed, and I will address this also afterwards. Resectability of the tumor depends on the institutions. This is, to my opinion, of utmost importance. If you are experienced pancreatic surgeons, you will have much more success in resecting advanced pancreatic cancer compared to unexperienced colleagues. This is a study. It is not. It is very old, but it is actual. This is from a specialized pancreatic cancer center in the Johns Hopkins Medical Institution, and they compared patients that were explored, surgically explored in other hospitals and declared irresectable, and these patients were then re-explored in the Johns Hopkins Hospital and afterwards compared with these patients primarily resected in the Johns Hopkins. And what is important and what you can see, 2/3 of the patients that were declared not resectable in other institutions were easily resectable in the specialized center, and the results are absolutely comparable. The mortality is a little bit higher compared to the primary resection, but certainly these are re-explorations some 6 weeks after the first intervention, and the results in summary are very good, mortality rate of 4%. So you have to select the institutions where you send your patients with pancreatic cancer. Portal vein resection, very important to my opinion, and it is important to understand this does not mean that you have advanced disease. Portal vein infiltration of the tumor is not a T4 tumor, it remains a T3 tumor. It's just an unlucky position of the tumor which grows nearby the mesenteric vein or the portal vein. So this is important because in some institutions, tumors that grow in that region and that infiltrate the mesenteric vein or the portal vein are declared non-resectable. And therefore you have to check whether your surgeon is able and willing to resect these tumors. Here you can see this is the divided duodenum, and this is the tumor with the pancreatic head, and this is the superior mesenteric vein, and this is the portal vein, and you can easily resect, and in most of the cases we perform an end-to-end anastomosis. And as I said before, this is a measurement of the quality of surgery in your institution. Totally different is infiltration of arteries. It is mostly the celiac trunk or the superior mesenteric artery. If you have an infiltration of these structures, then you definitively have advanced disease, and therefore the results are worse. And this is a work from Hamburg, from the Itzbicki group, and they analyzed a group of 30 patients in which they performed arterial en bloc resection, so en bloc resection with a tumor, and compared it with patients that underwent standard pancreatic resection, and group 3 were patients that were unable to be operated, and these are the results. And what is important, so the benefit for the patient is very small, and what is very important, we have a perioperative mortality of 16%. And so balanced, you have to say that arterial resection, to keep it short, arterial resection is only meaningful in very selective cases, and especially resection of the celiac trunk is most probably not meaningful, not sensible for the patient. And this is even worse, superior mesenteric artery infiltration. This is also for experienced surgeons a thing that we don't like to do, and you see in 6 years only 13 studies included only 70 patients, so some surgeons tried to do it, but most of my colleagues gave it up. Why? Because it has definitively no survival benefit for the patient, so infiltration of the superior mesenteric artery should not be resected. This is an exception. I told you the tumor which grows here nearby the portal vein early infiltrates the portal vein, and what we see relatively frequently is a tumor that infiltrates the gastroduodenal artery, and in this way pulls in the bifurcation of the hepatic artery into the tumor. This is, I would say, a special case. We see it once every 2 years, but also other colleagues see it, and in these cases you may resect the artery because this is not advanced disease. And you see here, this is the common hepatic artery, and here the bifurcation of the gastroduodenal artery is pulled into the tumor, and here the atrophic hepatic artery, and this is easily resectable, and you make an end-to-end anastomosis, and afterwards we resected also the portal vein. This was a young man, and I think is meaningful for the patient, but this is an exception certainly. What about multi-visceral resections? We have some papers that deal with that issue. This is certainly a paper from Heidelberg. 1 to 4 infiltrated organs were resected. Every 5th patient received a portal vein resection. Surgical morbidity is higher. Re-laparotomy in every 5th patient. The mortality is doubled. The authors conclude that it is acceptable and can be performed. I think these are cases where we have to discuss with the patient, and we have to see the individual situation of the patients. Maybe you would not do it in an 80-year-old patient, but you would do it in a 40-year or 50-year-old man or young woman. So it can be done, especially in pancreatic body and tail tumors. We do it relatively frequently. The median survival is surely much better compared to no resection. Very interesting, what shall we do with limited liver metastasis? I don't want to go too far. It is certainly a big difference whether a liver metastasis comes up after 1 or 2 years after surgery, or whether you have synchronous liver metastasis. So as a visual surgeon, we have the discussion with limited metastasizing disease in case of esophageal and gastric cancer, where we are more aggressive than we were some years ago. In pancreatic cancer, we have relatively frequently the situation that we explore the abdomen and we find in a young patient 1 single liver metastasis. And in former years, we gave up and performed double bypass. And whether this is really true in this study, the patient has a benefit if we synchronously resect the liver metastasis. This is very true for pancreatic head tumors, not so much true maybe for pancreas body and tail tumors. This is all statistic, but in the end, I think the patient will have a benefit if we resect the tumor. It certainly depends also from the trauma of liver resection. We wouldn't definitively not combine hemihepatectomy with a Whipple procedure. This would be absurd, but if you have a liver metastasis that is easily resectable, I think then you should do it. What about neoadjuvant chemotherapy? I want to keep it short. We have a very good collaboration with our department, with Professor Zoller. We discuss these patients. Very important is that if you have borderline resectable disease and you perform neoadjuvant treatment, you have to know that in around 2/3 of the patients afterwards, you will, as an engaged surgeon, a dedicated surgeon, you will be able to perform an R0 or R1 resection, which is beneficial for the patient. The problem is that you make your neoadjuvant treatment, then you make your CT scan, and you see the advanced tumor. And what you don't want to see are liver or lung metastasis. This would mean that you would not operate on that patient, but if the tumor is smaller or has the same size, then you are obliged to explore the patient. And this is very important. As a surgeon, you have to prove irresectability. So you open the abdomen, when you see a large tumor, when you see a lot of fibrous tissue, abutment to the arterial vessels and so on, and then you go on and resect, and you take multiple frozen sections. As long as malignancy is not proven by frozen section, you have to go on. So in a lot of patients, this fibrous tissue is not vital tumor tissue, no vital tumor cells can be found, and then you have to resect the tumor in this fibrous tissue. The advantages is clear to everybody. We possibly downstage borderline resectable disease. We have the possibility to assess the biology of the tumor. So in some patients that develop lung or liver metastasis during neoadjuvant treatment, we spare unnecessary surgery, but certainly it is a delay of time and potential curative surgery. We have side effects and time loss for patients with an eventual very limited life expectation. Rare cases are local recurrences in pancreatic cancer. Everybody who is experienced with pancreatic cancer knows that most of the recurrences will be generalized disease, so hepatic or pulmonary metastasis or peritoneal carcinomatosis, but in some patients, even late after primary surgery, real local recurrence comes up, so mostly in the location of the resected pancreatic head. And the question is it sensible, meaningful for the patient to resect these tumors? And this is a nice work also from Heidelberg, and you clearly see that it is definitively meaningful for the patient. The blue line are the resected patients, and the yellow one, the not resected patients. Certainly, this is these are highly biased patients. This is definitively clear. A patient that develops a local recurrence without generalizing disease is a very special case, but these cases have benefit from tumor resection. This seems to be a little absurd on the first view because you see resection plus intraoperative radiochemotherapy has a worse outcome compared to resection alone, but this can easily be explained because the resection plus IORT is done in patients that have where the tumor was not completely resectable, so a R2 situation, and then IORT is administered. And this is exploration plus IORT without, so IORT is working in case that you cannot do anything for the patient, and here it is nicely seen R0, R1, R2, and no resection. So if you have a patient with an isolated recurrency, I think it is beneficial for the patient to do a resection. So I conclude pancreatic resections can nowadays be performed with a very low mortality rate and a low morbidity rate. Radical resection for pancreatic cancer is absolutely meaningful. Portal vein resection is a standard procedure. Neoadjuvant therapies bring us insight into the biology of the tumor and are useful to downstage borderline resectable pancreatic tumors. Arterial resections are not meaningful in most of the cases, with exceptions. Multi-visceral resections, cancer metastasis, and resection of local recurrence of pancreatic cancer can be meaningful in selected cases. Thank you.